This topic we're going to be going over is electrolytes. First electrolyte we're going to be talking about is definitely potassium. Potassium is very important. You have to know everything. Of all the electrolytes that's in our body, if you don't know potassium, I'm a little worried because you need to know this guy. So let's dive down into the lecture real quick. First of all, let's talk about what potassium is. One of the electrolytes is responsible for membrane potentials in our body. It's important for our heart. Sodium potassium pumps are constantly running in our body, keeping the electric neutrality between cells, all that good stuff. But we're going to stay clinical. So what's the normal potassium? Normal potassium in our body, which is extremely important that you know that, the normal values usually run between 3.5 to 5.0. I extremely recommend you remember that number, especially when you're going to be tested on it. It's going to be in the hospital, it's going to be on the chart. But this is usually what normal body potassium runs around. Where is most of the potassium in our body? Usually they're inside the cell, right? If you remember your basic physiology, if I take a little cell here, most of the cells inside contains a lot of potassium. And on the outside, a lot of sodium. So that's why you have about 3.5 to 5.0 potassium inside each cell, around 140 sodium outside the cell. And there's a little pump outside that's constantly making sure we're pumping out the sodium, right, and bringing in the potassium. That's the sodium, potassium, ATPase. And this is kind of how it helps our body cells kind of maintain electric neutrality. Now, there's two things that can go wrong. So think about it. If I have this pen, right, our body always has to maintain homeostasis, right, which is the maintenance of body balance. So potassium number runs between this number, but that's not always true. Things can go wrong. So let's say this is where the normal potassium is, right? It runs always parallel like that. The two things that can go wrong. It can go way too high or it can drop way too low. Those are the two things. If it's too low, we call that hypokalemia, which means the number will be less than 3.5. If the number is greater than 5, we call that hyperkalemia, which means the number is greater than 5.0. Why do we care? Why do I care if my patient comes in and I look at their labs and I'm like, oh my goodness, the potassium is very low. Or when I look at it, the potassium is very high. Because it can cause arrhythmias. And arrhythmias are bad. These are conduction disturbances in your heart that can cause people actually to die. So your patient is going to die if you don't fix their potassium. So since we now know where potassium is going to be going, either too high or too low, let's kind of talk about causes. What can cause either the potassium? So we have regular K, right? So we can break it apart into two, into hypokalemia, and we can say hyperkalemia. What can cause the potassium to drop, and what can cause the potassium to go really, really high? One of the first things we're going to go over is how do we lose potassium? How does hypokalemia happen? One of the settings that hypokalemia can happen is in the setting of alkalosis. Now let me explain why alkalosis causes hypokalemia. Now, if you haven't watched the video on metabolic alkalosis, this is another review. In an alkalosis, remember I told you in the mind with the pH, the formula is pH of just bicarbonate on top, hydrogen ions divided by PaCO2. If you haven't watched the video, make sure you go back and watch it. When there's too much bicarbonate outside the cell, and I'm gonna take a little bit, 1 minute here, just to draw out a cell. We said there's a lot of potassium outside the cell, right? And if there's too much bicarbonate in the blood, what happens is there's a hydrogen ion exchange mechanism that happens that takes this hydrogen ion, which means hydrogen ions plus bicarb, right, to form the sodium bicarbonate. You see that? So if I'm taking all these hydrogen ions outside, automatically this is going to draw potassium into the cell. Can you see that? So it's this ion exchange mechanism. So if I keep increasing my bicarb, I'm sucking out all the hydrogen ions, and in exchange, potassium is going to go in. That's why alkalosis, right? Alkalosis causes hypokalemia. So remember the mnemonic, alkalo, this is the potassium, there is low, because alkalosis. And also, if I give you a lot of bicarbonate, which we'll talk about in the setting of hyperkalemia, I want you to put that on your right hand and your left hand and kind of keep that in the back of your mind. The reverse is true for hyperkalemia. So we're just gonna, I just want to touch about what causes hypokalemia and what causes hyperkalemia. In the setting of acidosis, right? In the setting of acidosis, what happens? You know your bicarb is low, right? And there's a lot of hydrogen ions. So if there's a lot of hydrogen ions outside, the cells are going to lyse in the presence of an acid. Remember, if you haven't watched the video metabolic acidosis, acid is bad for you. It breaks things apart. So the acid is going to break down the wall, and all the potassium are going to run out of the cell. And thus your potassium is going to be what? Really, really, really high. Now, where else can we lose potassium? Most of the potassium in our body is usually actually occurs in the kidneys. Most of the potassium, the excretion of potassium. Let me take you back to basic physiology so I can explain to you why we lose potassium somewhere else. In the kidneys. In the kidneys, there's the aldosterone stimulating the cells inside the kidneys. The aldosterone effect, which is going to what? Increase sodium uptake and causes potassium to be excreted through the kidneys. So that's another way we lose a lot of potassium in our body. Renally, and aldosterone plays a big track. We also lose it through the GI tract when we have a lot of diarrhea. Now, let's talk about hyperkalemia first. That's one of the, because it's very important that you understand this concept. So we're focusing on too much what? Potassium in your body. In the setting of hyperkalemia, we're going to talk about, we just talked about what causes it, right? We're going to go ahead, also talk about how we're going to go ahead and treat these patients. Now, let's talk about the causes of hyperkalemia. We talked about one, right? So let's go ahead and talk about causes. We said acidosis, and in the setting of acidosis, it depends on what is causing it. So you got to figure if it's anion gap acidosis or non-anion gap acidosis. But that's for you to figure out. And if you don't know that, remember the multi-pause mnemonic. Just go back and watch the video of what? Metabolic acidosis. That will definitely clarify it. So, another way, renal failure. Very important. When your kidney's not working, right? Remember I just told you your kidneys inside the nephrons. Let's draw a nephron real quick. Right? You got your beautiful nephron. And then all the way down, right? And you've got the principal cells and the chief cells, actually just the principal cells actually, and the intercalated cells that believe inside the kidneys. You have aldosterone acting as the distal convoluted tubules, causing, this is actually a distal convoluted tubules right here. This is the collecting duct. Aldosterone acts here, causing increased sodium reabsorption and causing a lot of potassium to be lost inside the kidneys. So if I have hyperaldosteronism, what do you think is going to happen? Actually, I take that back. We're talking about renal failure. Sorry for that mistake. When you have kidney failure, you can't excrete your potassium, right? So automatically you start to what? retain all the potassium in your body, because your body is smart. It doesn't want you to retain a lot of potassium. So when it's working right, the aldosterone works right. You lose some of the potassium, you retain the sodium. But if you stop working, the reverse is true. You start to retain a lot of potassium. What about if you have Addison's disease? What is Addison's disease? It's an autoimmune destruction of what? Of the adrenal cells, right? And you got adrenal, so we're going to review this in the endocrine, but we can talk about this. In the adrenal gland, right, you have the three layers: the glomerular, the fascicularis, and reticularis. And you have the adrenal cortex, where your steroids are made, right? You have the cortex, you have the medulla. Inside the medulla is where norepinephrine and epinephrine is made. In the cortex, right, is where what? Aldosterone. Now, I don't want to give it away, but I might as well just talk about it. The mnemonic is salt, sugar, sex. The deeper you go, the sweeter it is. You can't get better mnemonic than that. So as you go down through the adrenal cortex, which I'm going to go over extensively in the endocrine chapter, you're going to see the salt component is where aldosterone is, right? So if I have autoimmune destruction of my adrenal cortex, what happens? I knock all the cell layers out, and all of a sudden I can't make aldosterone. What does aldosterone do? Remember, if we absorb all the sodium, it what? Pushes out the potassium, you can pee it out. But what happens in Addison's disease, once you destroy the aldosterone layer, all the cells are dead. So you keep retaining all the potassium. So you get hyperkalemia. So we talk about three things so far: metabolic acidosis, due to renal failure, Addison's disease. How about this? If I give you a pill that allows you to excrete all the potassium in your body, don't you think that would also actually causing you to retain all the potassium in your body? Don't you think that would also affect you? Have hyperkalemia? Let's think about drugs for a second. Right? We have potassium sparing agents. I call them aldosterone inhibitors. Who are those guys? Let's talk about one of them. Spironolactone. Notoriously known. Right? You can give amiloride and triamterene. So these are all drugs that can cause you to retain the potassium. They're potassium sparing drugs. So if they inhibit aldosterone, especially spironolactone, this two doesn't, but spironolactone does inhibit aldosterone. What happens when we inhibit aldosterone? It stops doing its job. It normally allows you to keep the sodium and lose the potassium. So what happens? The reverse is true. You start to what? You lose the sodium, you become hyponatremic, and you become hyperkalemic. What else can cause elevated amount of potassium in your body? How about this? ACE inhibitors. Remember? Angiotensin converting enzyme inhibitors. One of the side effects of ACE inhibitors is what? Cough, right? And also angioedema. Extremely important. But they are notoriously known to cause hyperkalemia. If you know these three things, you become a rock star in the hospital, because your attendant is going to ask you, what are the side effects of ACE inhibitor? Wait a minute. They do cause cough, they cause angioedema, they're contraindicated in pregnancy, and they also cause hyperkalemia. So you want to remember that. Okay? Now, what else can cause elevated amount of potassium? We already talked about acidosis, tissue breakdown, But I want you to remember one thing before we go ahead and keep going, because in the hospital it's a different story. When I get a lab value of elevated amount of potassium, let's say like a 6 or 7, it's usually because it's a lab error. So the most common cause of hyperkalemia in the hospital, and not all of these guys, it's usually when we draw the blood out and we put it in a test tube, we put it on the rack, the lab tech puts it on the rack for so long, the cells break apart, they release all the potassium, and you think it's what you call a hemolyzed sample. Make sure you remember that. So, I would say the most common cause is a what? Hemolyzed blood sample, which simply just means in the test tube, you got a lot of red blood cells in there, and if they sit around for too long, they break apart, and they release all their potassium. So make sure you remember that. GI bleed can also cause what? Hyperkalemia, because all the blood is breaking apart and is releasing all the potassium out. How about if I don't have insulin? If I don't have insulin, let's talk about that for a minute. Insulin deficiency. Let's talk about that. Insulin deficiency. So, we talked about insulin works. Let me give you a quick review of how insulin works again. So, on every cell, I told you we have a sodium, potassium, ATPase pump. And the job of insulin is to stimulate this pump, right? And insulin comes and binds here. We're going to use insulin right here. When insulin binds, it's going to stimulate the sodium, potassium, ATPase pump and causes potassium to what? To shift into cells. So, when they bind, what happens? All the sodium is being pumped out, and all the potassium is being brought back into the cells. So, what happens if I don't have any insulin at all? The sodium ATPase pumps are not working, and my potassium is high on the outside because they need that concentration gradient to come down, and you become what? Hyperkalemia. So, we've talked about things that causes hyperkalemia. Now, it's another terminology called pseudo-hyperkalemia. Let's kind of go over that a little bit. And I think we pretty much talked about it. There's other ways your potassium can be high. So we talked about this. And so because I'm going to review this again, let's just put insulin deficiency here. That's a term they call pseudo-hyperkalemia, which means it's fake, it's not really real. The first one is what? I told you, hemolysis. How about if I use a tourniquet? So if I take a tourniquet, if somebody's bleeding and I use a tourniquet and I hold down around the wound, what happens is as the blood is starting to get through, it starts to break apart and the cells start to break down, and all of a sudden you get this fake hypernatremia because all the hemolysis that's going on at the joint. That's why they tell you not to really tie the tourniquet too tight because it can cause hyperkalemia, but it's kind of pseudo because the cells are just breaking apart and releasing all the potassium out. So you want to usually remember you don't want to keep it for too long, because if you do keep it for too long, that's usually one of the complications of putting on a tourniquet for too long. Now we'll talk about all the things that causes it. Acidosis, right? Renal failure, Addison's, drugs, insulin deficiency. Think we need to fix this patient up. So let's talk about how to treat, because that is exactly where the bread and butter is for this lecture. Treatment. And I spent some time to try to make sure. So, how do we treat hyperkalemia? So I'm going to start with a case. I have a 45-year-old male presents to the ED is complaining of weakness and palpitations. Is also complaining of some nausea and vomiting. Try to give you a really good case here. It says they're fatigued. Also, now when they tell me they have palpitations and they're weak, I think something's either wrong with their heart. It could be some kind of electrolyte abnormality. So the first thing we're going to go over is what are the signs and symptoms of this kind of electrolyte abnormality before we actually treat. So let's work up this patient. Let's work him up. So symptoms, he said, is fatigue. He feels weak. He has some palpitations in his chest, some nausea and vomiting. And he has a past medical history of renal failure. So, you know a little bit about this guy. He has kidney issues. So when you see somebody has renal failure, the next thing you want to know is what is their potassium? And we checked his lab on the side. We got a stat potassium, and it was 7.9. Now, that should scare you a lot. Because if you're not scared with that number, I'm pretty damn scared. So, we know this guy has hyperkalemia. The signs and symptoms usually fatigue, weakness, palpitations in the chest. So, what are we going to do? Now, that's where we start to treat. The first line of management you want to do is to order an EKG. You want to get an electrocardiogram. So let's talk about this because this is where the bread and butter of hyperkalemia is. What is the first sign you see on EKG when you see a patient? With hyperkalemia? You see, so we have a P wave, we have a QRS complex here, and we are I want you to take a quick look at this T wave. These are called peaked T waves. You want to know this. This is very, very important. See how the T waves are higher than the QRS complex? That is characteristic, classic finding of hyperkalemia. They're really, really pointed, and they're taller. They're about greater than 10 millimeters of T wave, greater than your QRS complex. That is the classic finding. You do not want to miss that. Now, the second thing you're going to see is what? PR prolongation. So let's draw that. So the PR interval is between 120 to 200. So that has to be less than 200 milliseconds, right? So all of a sudden the PR interval gets really long. So from P to R, actually, let's see. See the P wave. Let's put a little Q here. And here you go. So we have peak T waves, prolonged PR interval right there, right? The third thing that happens is widening QRS complex. So let's follow that. So prolong that. Can you see that? So that's the T waves, QRS complex, PR interval, and then a sine wave. You don't want to see a sine wave in the hospital. That is utter badness. So let's just use this space here. We're just going to erase this. And you can forward and see at that point, basically you're getting that. This is bad. Really, really bad. The patient is going to die if you don't fix this right away. So, like we said, the first thing you see what is peak T waves for long PR intervals. You see Wagging Qrs sine wave. That's really bad. So how do I remember this? It's so hard to keep everything straight. Yeah, I know. It's hard. So one of the surgeons I met told me this is the mnemonic. So you draw a regular P, Q, R, S, T, right? So the way you remember is you hold the end of the peak of the T wave, and if you keep pulling it, right? If I pull this and pull this, just like the thread, it gets wider. So if I pull this apart, just right at the tip over here, it gets picked, and eventually the PR gets longer, the QRS gets longer, and eventually they develop a sine wave. It's just pulling the tip of the thread, and that's how you remember the EKG characteristics of hyperkalemia. Pretty easy, isn't it? That's my job. That's why I'm here, guys. So, what is this? So now that we ordered EKG on our friend, and he has peak T waves. That was his EKG changes. So what is the first thing we're gonna give him? You want to order calcium gluconate or calcium chloride. Now, how many milligrams? 1,000 milligrams of each. So which one do we always use in the hospital? We always go to calcium gluconate. We give it IV. We give it to the patient. Because why are we giving calcium as our first line? Because calcium stabilizes the membrane potential of the heart. That's why we give calcium. You want to stabilize the membrane potential of the heart. So that is very important, because if you don't remember that, that's going to hurt your patient. That buys you about 15 to 20 minutes for you to fix this potassium. But we're not even touching the potassium. The whole point of giving calcium gluconate is what? Is to stabilize the resting membrane potential of the myocardial membrane. Now, we're not fixing the potassium yet, so I want you to follow me. Now, you give 1,000 milligrams of calcium gluconate. That's your first line. You tell the nurse, we got to give this to this patient. But why no calcium chloride? It's the reason why we don't give calcium chloride to the IV. Because calcium chloride can damage your blood vessels and can sclerose it. But when don't we give calcium gluconate? So calcium gluconate, if you look at calcium gluconate, we have calcium gluconate here in the vial, and we have calcium chloride. So I'm just going to draw, this is a calcium molecule, and this is gluconate. Calcium molecule, gluconate. Calcium molecule, gluconate. On the other side, this is chloride, 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 and we have some calcium next to it. The reason why I said calcium chloride causes sclerosis of the veins is because, think about it, this is a smaller molecule. That means we can pack a lot. So if I put 1,000 milligrams of this in a vial, it's highly concentrated, high concentration. So if I put it through your IV, it's going to damage it. However, look at this calcium gluconate, it's much bigger. They're not going to damage it. But there's one exception where we don't give calcium gluconate. How is calcium gluconate metabolized in our body? If I give you calcium gluconate, it goes into your IV, it has to go straight to the liver. Oh, and when it gets to the liver, this calcium gluconate is now broken apart into free ionizable calcium and gluconate. So if my liver is not working, who are those? Liver cirrhosis patient. You can't give them calcium gluconate. It's not going to work. The liver's dead. You're wasting your time. So give them what? Calcium chloride instead. Okay? In a cold, when the patient is crashing and the patient is dying, hypertensive, tachycardic, you have arrhythmia, What do you want to do? You want to give them calcium chloride because it's high concentration. We don't care about the veins at that point. So that's the big distinction. It's always 1,000 milligrams. But all this good stuff we're doing has no bearings. It's not fixing the potassium. So how do we fix our potassium? That's the next one. So we're giving calcium gluconate. Everybody's happy. There's two ways we're going to fix this potassium. One is by shifting the potassium, and two is by eliminating it. So how do we make a shift? The first thing you want to give is what? You give 10 units of regular insulin. Plus what? A D50 of glucose. Now this is very important that you know this because I just explained. So if you want me to go over the mechanism again, you can just rewind the video and you can see I have mentioned how does insulin work. It acts on the what? Sodium potassium ATPase pump allows them what? Pump out the sodium and bring in the potassium. However, what does insulin do to your body? It drags in glucose. So you have to give them D50, which is about 25 grams of glucose, so these patients don't become what? Hypoglycemic. Very important. Just don't give them insulin, or drop the potassium, but they become hypoglycemic. They can go into seizures, they can go into coma. You don't want that to happen. So now that we've done that, now we're touching the potassium, you can also start to give them what? Albuterol. It's a beta-1 agonist. What does beta-1 agonists do? They draw potassium into the cells. You want to remember that. So you put them on albuterol, let them start breathing albuterol, start IV drip of regular insulin, 10 units, give them some D50 to go with it, start them on 1,000 milligrams of calcium, and now we're doing something. Now they start to recheck the potassium as you're doing all these therapies. Now, when do we give bicarbonate? Everybody wants to give the bicarb. The only time you give bicarb is when the patient is in what? Acidosis. Remember, if they have metabolic acidosis, so how are we going to know the patient is in acidosis mode? You can check the anion gap. You check the anion gap, which is the sodium minus bicarb plus what? Potassium. Sodium plus, chloride. Sodium minus the chloride and the potassium together. That gives you the anion gap. If they have an anion gap, you can now determine it's an anion gap acidosis. Mod positive money kind of go that route, and you might start to want to give them bicarb at that point. So, but that bicarb, if they don't have any acidosis, you don't have to worry about the bicarb because sometimes it works, sometimes it doesn't. Now, we've done three things. We've stabilized the cell membrane potential. We start to shift the potassium back into the cells. How else can we do this? We can eliminate, right? So we can eliminate the potassium. And how can we eliminate? We can use K-exylate, which is what? It's a sodium-potassium resin. Basically, it draws out all the potassium and gives you sodium back into your cell. The problem is the patient can get dehydrated, and it doesn't really always work. So it's important that you know that. Or we can give them Lasix, which is what? Furosemide. Basic physiology. How does furosemide work? Furosemide is what? It's an inhibitor of this sodium potassium 2 chloride exchange iron pump inhibitors. And what happens is you develop hypokalemia because you excrete all the potassium out of your body through the kidney. So you can start them on Lasix. And the final but not the least is to what? Hemodialysis. You call nephrology, you put these patients on dialysis. Now you can wash all the potassium out of their cells. But before you wait for them to get on hemodialysis, it's very important. You want to make sure you start them with calcium gluconate, stat, 1,000 milligrams, giving them regular insulin with glucose, albuterol, and bicarb as needed. And that's how you treat the patient. And then you check this potassium, and if it's back between 3.5 and 5.0, you've saved the patient's life. So, In summary, we've talked about hyperkalemia, what causes them, acidosis, renal failure, talk about Addison's disease, right? Hemolysis is the most common. You can get pseudo-fake hyperkalemia from that. We talk about a case and what are the signs and symptoms. Usually the patients just feel weak and tired, so you want to pick that up, electrolyte abnormalities. Talk about how we work it up. We want to get a static EKG to look at those PT waves, prolonged PR, we can get bradycardic, a sine wave. And this is how we fix it, and then the patient should feel better. All right? I hope this lecture was very helpful. If you have any questions, shoot us an email at featuredteachingphysicians@gmail.com. Thank you.